Good afternoon, ladies and gentlemen. Welcome to the continuation of the Convention Symposium. I am Dr. Maylene Villarmosa, past president of the FPCCP Northern Mindanao Chapter, and I will be your chair and moderator for this session. The program will begin shortly. Meanwhile, may we remind everyone to please scan the QR code that's flashed on the screen to ensure that your attendance counts. For our symposium this afternoon, we will be having cardiopulmonary exercise test on center stage. We have with us very distinguished speakers who will talk on this topic. Our first speaker, Dr. Lenora Fernandez, is Professor 1 of the Division of Pulmonary Medicine, Department of Medicine at the University of the Philippines, Philippine General Hospital and College of Medicine, as well as section head of the Section of Pulmonology, Department of Internal Medicine at the Asian Hospital and Medical Center. She is consultant coordinator for the Comprehensive Ambulatory Care Respiratory Rehabilitation or CARE program and Stop Smoking program of the Philippine General Hospital. Together with Dr. Fernandez is Dr. Percival Punsal, who is the former head for Pulmonary Rehabilitation Section at the Philippine Heart Center. He is the chairperson for the Pulmonary Rehabilitation Ad Hoc Committee of the Philippine College of Chest Physicians. And finally, completing our panel is Dr. May Agno, a pulmonary specialist at the Lung Center of the Philippines. She attended several training and certification courses in exercise testing, such as the European Practicum on Exercise Testing, CPX International POETTS Clinical Exercise Training, and ACCP Cardiopulmonary Exercise Testing Certification, among others. So now we will hear the presentation starting off with Dr. Fernandez, followed by Dr. Punzal and Dr. Agno.
Good afternoon, everybody. I will be paving the way for the next two speakers. I'm the baby in CPEX. And I hope I'll be laying down the physiologic principles for CPET and as well as how we will go through it in terms of interpretation, but most of the cases will be given by Dr. Punzal. So thank you, Dr. Bernice de la Cruz, because 70% of my slides came from her. So what is cardiopulmonary exercise testing? I heard one of the people outside asking, what is CPET? So of course, I think everybody here knows that it is basically like a stress exercise test that the cardiologist would perform, plus with a lot of advantages of having expired gas analysis. Therefore, we are able to see the integrative response to exercise by our patients. And it is highly sensitive and it does give us a lot of information. So it's like the Ferrari of all exercise testing. And that's why the cost in the Philippines would range from 4,000 pesos to 13,000 pesos in terms of when you now refer your patients for CPET. So it is not only for James Bond, but a lot of centers here in the Philippines nowadays perform CPET, so you can refer your patients. Our physiologic basis, of course, is to put the body to stress so that we see how the body would respond to that. And the usual indications would be if you have problematic patients with dyspnea that you cannot really differentiate whether it's more of pulmonary rather than cardiac, and you want to go deeper into why your patient has exercise intolerance. And the cardiovascular people, the cardiologists, would usually even do that for their pre-op clearances for their patients, for their procedures, even for transplant. And Dr. Punsal will talk about this more. And for us pulmonologists, then we do have a lot of utility for that because we want to differentiate what is really the exercise limitation. We do it for pre-op purposes and also for evaluation for pulmonary rehab, and we make that as the basis for our prescription for pulmonary rehab. So of course there would be contraindications. We can't let a patient go into a form of stress that they cannot tolerate, and these are the usual absolute contraindications. So I just performed a CPET last Monday on a patient, and she had chest pain right in front of me, and that was the reason that she stopped her exercise test, and it was good enough that I was able to have at least 6 minutes of exercise testing for her. So these are the things that you take into consideration. Therefore, these are the usual fields of specialists that would prescribe or request for a CPET. So I hope this will be more of something that you will request in the future. So why is it expensive? Because the equipment is expensive. It's a Ferrari. So it's 10 million to 13 million pesos. And that's why the apex hospitals of DOH already has it, even in Cagayan de Oro. So therefore, Dr. Senisa will hopefully start the CPET running in Cagayan de Oro. So this is how it looks. And we can use a cycle or a treadmill. And the preference, I've worked with both, and now my preference really is a cycle because we're able to really quantify the workload for our patients, and it is safer, but the treadmill would simulate the usual functional activities of the patients, and that's why there is also the preference for treadmill. And the protocol, so what is the name of the game? You put the body to stress, and therefore you try to have them undergo something, and we usually do it with an incremental exercise protocol. And for us to really get an adequate response from the patient, at least more or less, your test should run for at least 10 minutes or at least 5 minutes, and then we try to gain the most or the maximal effort from the patient. So of course, you will have some who would be malingering. They would try now to decrease their work capacity or their effort so that they would get a poor result, and it's up to you now to differentiate if they're one of those. So these are the usual protocols that we use. So for example, right now in the private hospital where I conduct it, we use the incremental. It's either we run from 5 to 25 watts every minute, the load. So the patient goes to the resting phase and then the unloaded phase, so that would be the warm-up. And then we do the incremental phase, as I mentioned, 5 to 10 minutes minimum. And then the recovery phase is usually 3 minutes as prescribed by the ERS and the ATS. Now, what do we measure? We measure these variables, so there are a lot, and that's why you really have to get your brain together. It takes me an hour to really come up with a full report for a patient after conducting the CPET. We ask them, of course, about their symptoms as they go through the incremental test. We use the Borg scale, so we have a Tagalog translation from it. So that's our language, whether the fatigue and the leg tiredness during the incremental test runs from 0 to 10. So when do we end the exercise? As we mentioned, we try to get the most information. Then it is symptom limited, so when the patient says, I'm good now, my Borg scale is 7, it is stopped. Or if there are other symptoms of, for example, muscle fatigue. And we can also target for the maximal predicted heart rate, and we will say the patient did good effort with this incremental test. And of course, these are the criteria, as I mentioned. The patient I had last Monday terminated the test herself because of chest pain. So we lasted for 6 minutes only and 20 seconds. So the CPET report that you get from us would contain the following. So we go through them to see what would be the main organ that is involved in terms of the exercise limitation. And these were the tabular data report from the equipment of Dr. De La Cruz. We also have the same equipment. So we have the tabular data. We have the scary nine panel plot. And then we garner now the report, and that is given to you. So how do we now interpret the results? So first and foremost, I mentioned we have to make sure that it was adequate in terms of the stress given to the patient. We determine that, and then we now check if the exercise capacity of the patient was adequate, if it was normal, or if it was low. And then we see initially the cardiac response, and then the ventilatory response, and then we now analyze everything together to see what would be the limitations and what organ systems are probably involved. So let's first go to VO2 max. So this is the gold standard for us to say if your patient has low exercise capacity. The other term is anaerobic threshold. That's the other variable that we determine to see their exercise capacity. We go now to normal exercise physiology. So remember, your system has to be put to stress. Therefore, your muscles will need what? ATPs, of course. And therefore, you have to see this aerobic glycolysis pathway, because this is the way our body would generate the ATPs. How do we get the ATPs? We go through the aerobic glycolytic pathway, the electron transport chain, for you to get the most ATPs to provide that for your muscles. And remember, your ETC runs on oxygen. So look at the molecules there. So they've seen that for a normal person like us, if we now undergo exercise, you go for your spinning class, you go for your sprint, you go for your golf, or that's not too heavy an activity. If you go for maximal activity, then they saw that the rate-limiting step is the delivery of oxygen at the capillary level. So that determines now the exercise capacity of a patient. So if you are lagging in that, then you now would have a lower exercise capacity. So you know now the muscle fiber shifting from 1 to 2 for you to gain, for example, so we'll talk about that later. So what is the name of the game? Pre-capillary O2, and that means it would be oxygen uptake, the VO2 that will be the main determinant of exercise capacity. So how do you now get VO2? So VO2 max now, when you have your maximal exercise test, is, as I mentioned, the recognized standard. So we are going into VO2 max. So look at your Apple Watch, look at your cell phones now, you have that. That is VO2 max. And how did the phone do that? So they did that by predicting based on your age, what would be your predicted VO2 max, and if you're achieving that with the walking that you're doing. So you are basically looking at the lungs going into the heart, going into your mitochondria in your muscle cells to see if you have enough VO2 uptake to now cause for your patient now to be efficiently exercising. So if you remember now your fixed equation, this is actually the basis for all exercise physiology. So for you to get good VO2 uptake, there has to be good offering of your oxygen and good extraction of your oxygen by your cells. And that would be the Fick equation. So extraction would mean cardiac output. And what is cardiac output? Heart rate times stroke volume. And that's why the predicted heart rate determination of VO2 max is based on the Fick's principle. So the amount of blood pumped per heartbeat at maximum heart rate times the amount of oxygen the working muscles are able to extract from the blood passing through them. That is the main principle behind exercise physiology. It is not your respiratory rate. It is not the adequacy of your ventilation that is the main to deliver O2 uptake. It is your cardiac output times the extraction of oxygen. And of course, the efficiency behind it. So a normal person would terminate exercise by reaching their maximum cardiac limit. And therefore, as I mentioned, heart rate times stroke volume, this is the main driver now for an increase in cardiac output at moderate to high intensity. That's why the watches and the others are approximates for that. So we go now to VO2 work rate relationship. This is, as we can see, it's linear. As you increase now your work, your VO2 would linearly also increase, and when you stop work, it would go down. So here, when you now reach the maximum in terms of the symptoms, your patient will say, okay, I'm tired now, that's it. Now, usually, we are trying to reach for a plateau. The plateau is the VO2 max, but seldom are we able to get that when you are symptom limited. And therefore, it's only the peak that we reach, and that would be good enough as an approximate of your VO2 max. Therefore, VO2 max is equal to VO2 peak. And here, this would be, as I shown here, the estimate of the VO2 max, since, as I mentioned, seldom do we reach it if it's symptom limited. There are, of course, reference values because it depends now on the nature of your muscles, the height, the weight, and the sex. In the Philippines, we already have reference values that was done in PGH with Dr. Roa, Dr. Garcia, and Dr. Maghuyop. And these are now the formulae that we can use for the Philippine population. But the Pulmonary Hub and the COPD Council need to sit down on this if this will be sufficient for the Filipino population. So what are the conditions now that would decrease VO2 max? Of course, cardiac. Pulmonary, of course, because that would participate in the oxygen delivery into the cell from outside. And then O2 extraction by the muscles. And of course, some would decrease their effort for one reason or another that could decrease your VO2 max. So that's number one. Number two is anaerobic threshold. That would be another determinant of the exercise capacity. So remember, when you now exercise freely to the max, what happens? Your aerobic glycolysis will not be sufficient anymore because of what? The decrease in capillary O2. Your muscles need so much, and you can only pump so much with your cardiac output. And therefore, your muscles now will shift from muscle 1 fiber to the muscle fiber 2. And what happens? Anaerobic glycolysis will set in. So that would be the trigger there. So that anaerobic glycolysis or metabolism will happen, and there would be the production of lactic acid. But remember, the aerobic metabolism still goes on, even if there's anaerobic glycolysis going on. So with the buildup of lactic acid, what now happens there? You see it now, if you get blood lactate, if you have an A line while you're doing the CPET, you can get that, but we don't do that here, I think, in the Philippines. The time that, of course, anaerobic glycolysis would set in, that is what we call the anaerobic threshold or the lactate threshold. And what happens now with the body? When you increase the lactic acid, from what you remember in your physiology, you need now your bicarb to already bond with your H+, and then the byproduct will be CO2. So where would the CO2 go? Of course, that would be the function now of the lung to exhale the excess CO2. And that now would lead to what we call the ventilatory threshold here. So remember, anaerobic threshold is defined, therefore, as the point where anaerobic glycolysis would set in. One way to determine that would be to check the blood lactate, which is difficult. And the other one now would be to check those graphs where that point will emerge. So it usually happens 40 to 60% of the maximum work rate, and it is a good index of the aerobic or endurance capacity of a person. And it is usually what we use also to prescribe, that we get the VO2 at the point of anaerobic threshold. That would be the point that you'll get the training effect. You have to go beyond that. And that's the reason also when you go to your gym guru, that he will set a certain VO2 max for you beyond the anaerobic threshold to have the anaerobic metabolism going on. So how do we now determine the anaerobic threshold on CPET? So if you see here, as you now increase your exercise, your VO2, as we mentioned, is linear, but there would come a point where anaerobic glycolysis would set in, so that there would be a build-up now of your VCO2, and this V here marks now the point of the anaerobic threshold. So that's one method. The other method is what we call the ventilatory equivalence, and we'll talk about it more. So if you remember, what would happen to your minute ventilation as you increase your O2 consumption? It increases, right? And then your VCO2 would increase, the exhaled amount of carbon dioxide will increase at the point when your lactic acid will increase, and then the increase in acid will stimulate further your brain receptors so that you will have a further increase in your minute ventilation, because that would be the main stimulus there. So you can see here, your VeVO2 would go to a nadir first. It would go down because there's maximal O2 extraction before now the body would say, I can't do it anymore, and then it now shifts to anaerobic glycolysis. So here we see the nadir and then the buildup again here. And then your VE over VCO2 would be kind of linear. It will have a plateau here, because once lactic acid starts to build up, you still have some bicarb in your system, so that your CO2 will still not increase yet. It's only when your brain is stimulated already that there will now be an increase in your minute ventilation over your VCO2. So there are different 2 points, and we usually refer to the first point as the true anaerobic threshold, but that's sometimes a conflict for some people. So the other thing we look at would be what we call the respiratory exchange ratio, which is the substitute for your RQ, or respiratory quotient. This is VCO2 over VO2. So it depends now how much you ate in Summer Palace or in your lunch now. So if you have more fats, then your RQ or your RER will be less than 1. But as you now increase your metabolism, then more carbohydrates are used up so that your RER will be around 1. And then if it now increases to, as you exercise, you use up more of your carbs there, and your VCO2 would increase more than your VO2, then our target is 1.05. Beyond that, you can say that the patient was able to exercise enough for you to get good results, or they did an adequate exercise. So for my patient, even if she just ran for 6 minutes and 21 seconds, her RER was 1.2, and therefore I concluded that it was enough exercise for her. I could get a good result. So what would be the application of the AT? So this is what I mentioned. It usually happens at 40 to 60% of your VO2 max. And then it is reduced if you have any problems for that matter, ventilatory, circulatory, skeletal dysfunction, or even renal failure because of the increase in your H+. And as I mentioned, we use that now to prescribe the training program. You have to go beyond that to get good training effect. So this is the RER that I mentioned. This is RQ. This is the baseline that we talked about. And what we aim for in your exercise would be to get at least a 1.05, or for others, it's 1.15, for you to say that there is good effort in your patient. Okay, you're fine so far? Kinda. Okay, cardiac parameters now. We look at the cardiac response. This is the name of the game, right, for exercise prescription. And we look at heart rate. This is how our body responds to exercise when you go out for your jog. So there would be a linear relationship there. And then at the top, when you recover, it would go down. So the increase in heart rate is initially due to vagal withdrawal, and then later on sympathetic activation sets in. For cardiac patients, sometimes we get a bump here, and Dr. Punsal will explain it later how it happens after the recovery. So this is what I mentioned, and we have the predicted heart rate max. Everybody knows this, 220 minus the age. That would be the predicted heart rate, because it is something quite stable. If you have all the parameters there, we know that you're gonna hit it because of the fixed equation. We have the term heart rate reserve. For a normal person, if you exercise, do you want to hit your predicted heart rate? Yeah, you want that, right? So you don't want a big gap, because if you don't hit it, that means you did not have enough exercise. So that is the heart rate reserve. The heart rate max predicted minus the maximum heart rate you get during exercise. What you want is a small heart rate reserve to say that you exercised well. So it should be less than 20. And of course, widening of the gap of the heart rate reserve would mean what? Kulang yung effort mo, or may ibang problema yung pasyente, naka-beta blocker pala, or they were really not able to exercise to that degree. So like my patient, 6 minutes, 21 seconds did not get her that heart rate reserve. It was a very big gap, but the other parameters were adequate. The next parameter is O2 pulse. What is this? This is the amount of oxygen you extract per heartbeat. So this is an indication also of the efficiency of your cardiac system. This is an estimator of the stroke volume. Again, we go to the fixed equation here. And the O2 pulse is basically VO2 max over heart rate. How much oxygen per beat or per heart rate. And this is, as we mentioned, an indicator of stroke volume. So at exercise, your O2 pulse is usually 10 to 15 ml. And if it is decreased, that is a good indicator that you have a cardiac problem in your patient. Or it can happen with deconditioning also, or there's just early exercise limitation from these other diseases here. Okay? Okay so far? Next, ventilatory parameters. We're going now to the ventilatory system. So we're looking at the response again to exercise with your lungs. and of course, your ventilation perfusion. So we talk about minute ventilation. We increase, minute vent would be tidal volume times frequency. As you exercise, they believe that probably the receptors, the proprioceptors stimulate also the brain to increase our RR when we start exercising. So it would be, as we can see here, like a hyperbolic curve. As you increase your exercise, you increase your minute ventilation. What is increased there? Is it only respiratory rate? No. Both are increased, tidal volume and frequency. At the start, it's more of the tidal volume that's increased, and then later on, the frequency is the one that would increase. And here, we terminate now, we terminate exercise here. Why? Why are we terminating? It's because of the cardiac limitation, no, the O2. So this now, we don't usually reach inspiratory capacity at the end of exercise. And what is that gap? That is what we call now the breathing reserve. So the breathing reserve is the one that we look at to see if there would be a ventilatory problem or not. What is breathing reserve? That would be, that's supposed to be big for a normal person, no? So breathing reserve is computed by your maximum voluntary ventilation. You do a 15-second hyperpnea for the patient before you start the exercise testing, or you can approximate this times 35 to 40 from your FEV1. So this breathing reserve is supposed to be big for normal people. So for patients with COPD, what do you expect? They will have a smaller breathing reserve. So our language is as follows. Breathing reserve is the minute ventilation subtracted from the MVV over the total MVV, and then the normal breathing reserve is 20 to 30% of MVV, or more than 11 liters per minute. So look at this one. This is a normal individual and sedentary. As we mentioned, you never reach inspiratory capacity, and here MVV is here, that will be your breathing reserve. What is this? This is an elite athlete who knows how to increase his tidal volume and frequency so that he can go on to have a higher VO2 max. And look at his breathing reserve. It's not normal anymore, but he's a very normal person. He was able to do that because of techniques that he did. How about a COPD patient? Your MVV, FEV1 is limited right from the start, so that when he now exercises, because of the increase in the dead space, the dynamic hyperinflation that happens, he only reaches up to here in his VO2 max. And therefore, what is your breathing reserve here? This is his MVV, and he was only able to reach there. Is it increased or decreased? It is decreased in a COPD patient because of the lower MVV. Now, we go to, malapit ako matapos. Ventilatory equivalence would be, as I mentioned, these ratios. And we like this because this is where, as I mentioned, we determine the anaerobic threshold. This is the efficiency of ventilation. And as I mentioned, it drops this ratio before you go to anaerobic glycolysis. So the point here is what we use for anaerobic threshold. And this would reflect, again, the efficiency of your ventilatory system. So that's VE over VCO2, and these, of course, are the diseases that can now impair ventilatory efficiency. So second to the last, dead space fraction, that's your VDVT. We know this, and we get that from the alveolar gas equation. And usually, the VDVT, the dead space, should be less than 0.2 or 0.3. So how do we approach interpretation of the CPET with all these variables I've talked about? First, we assess, as I mentioned, the adequacy, and then if it's normal, and then we see now the response of the cardiovascular, ventilatory system, and the gas exchange. So these are the values that we look at to say that there's adequate, the test was adequate, and if the response now of the patient, if the VO2 max is normal or not. These are the values that we talked about also. This is what we peg, or these are our standards to say whether it's normal or abnormal. And we now make HIMAI, all those variables. So, for example, a deconditioned patient, VO2 max is decreased. What do you expect about the O2 pulse, it can be decreased also. And we see that the breathing reserve is preserved. Most often, VDVT would be preserved. So that's how you would detect them that they are just deconditioned. Heart failure patients, what's decreased? VO2, your O2 pulse, aside from the others. And for your COPD patients, this would be the pattern. For ILD, we usually see them in the pulmonary vascular disease patients. They really are very tachypnic at the end of exercise, 50 or more. That is usually our index that there is ventilatory inefficiency. These are the plots, the graphs that we look at, and they would correspond to the things that we've talked about. So therefore, in conclusion, so it's not simple, as you saw. It's an integrative physiologic investigation, and it's worth your money for your patient to go through CPET because you learn all these things about your patient. But it does not give you the definitive diagnosis, okay? And it's just there to help you now understand your patient better. Thank you.